I will also put out this case study report as well. I did make this one though. So, we might need a break. Keep going. Okay. Alright, so Mr. P is a 74-year-old male who is retired engineer. He's got a history of hypertension, hyperlipidemia, and type 2 diabetes. He reports occasional smoking, moderate alcohol consumption, and a sedentary lifestyle. He lives with his wife, who helps with daily activities. Okay. Anything stand out to you initially? He's gonna have a stroke. That's already Anna's guess. I hear hypertension. We don't like that. Hyperlipidemia, type 2 diabetes. Aren't those all contraindications or risk factors for possible stroke? Yes. He also smokes. He's got a sedentary lifestyle and he drinks, so he doesn't have a whole lot going for him currently.
Is it man and male? Does that make him more risk?
Slightly.
That was the question you said no to this.
Okay. So his wife brought Mr. P to the emergency department after he suddenly experienced weakness and numbness on the right side of his body. He was unable to speak clearly and appeared confused. The symptoms began approximately 45 minutes before arrival. Okay. So what are we already thinking? We already kind of said it.
He needs to go to CT?
He needs to go to CT, right? All right, to rule out what?
Ischemic or hemorrhagic?
Ischemic versus hemorrhagic. Good.
Maximum blood for
So upon arrival, Mr. P was assessed by the stroke team. They noted the following: right-sided weakness and numbness, difficulty speaking, confusion and disorientation, mild drooping of the left side of the face. Blood pressure was 170 over 100. We already said this, but CT scan, a non-contrast CT scan to rule out hemorrhagic versus ischemic. So the CT scan shows a hypodense area in the left middle cerebral artery. This results indicating a ischemic stroke diagnosis. So Mr. P is diagnosed with acute ischemic stroke, likely due to an occlusion of a middle cerebral artery. What risk factors increased his susceptibility to stroke?
Hypertension, hyperlipidemia, type 2 diabetes,
Sedimentary lifestyle,
smoking,
and
history,
alcohol.
and man and male.
It's basically all his whole life.
Yeah.
Basically. Yeah. Being Mr. P is his risk factor. Okay. What major outcomes are we going to expect to achieve from him?
Get him back as close to baseline as possible.
Okay. Are we trying to reestablish perfusion?
Yes.
Yep. So something like a TPA, right? Okay. Maintain his airway, his breathing, his circulation, right? So ventilator support if necessary, vital sign support if necessary. Aspiration risk is going to be on board as well. What about DVT risk?
Mm-hmm.
Yep.
Can we worry about DVTs?
Mm-hmm.
Are they going to be decreased in their mobility? They just had a stroke. They're probably not going to be moving around a whole lot. Good. Anything else?
Range of motion.
Range of motion, get that on board. What about his risk factors? Can we talk to him about that? Make sure he maintains his medication compliance. Make sure he has his type 2 diabetes under control, his hyperlipidemia under control. See if he'll quit smoking, quit drinking. But he's what, 72? 74? I'm good at this point. So.
How long after, if he got the T&K, would they start anticoagulants?
That's a great question. I could not give you an exact answer.
I mean, they would, because they obviously wouldn't immediately do it.
Right.
They wouldn't be getting Lovenox or Eliquis or anything.
It's on the tip of my tongue, and I can't tell you off the top of my head. They are going to prolong them. They're gonna usually put signs or something on it too. No IV sticks, no EG tubes, no intervention basically. And you're not poking and prodding at them. There's very specific criteria that you're gonna follow. And then after you give that TPA, you're gonna make sure that it doesn't turn into a hemorrhagic side, so you're gonna do the frequent neuro checks, frequent changes in LOC, that kind of stuff. Before they get discharged, though, they're gonna start on some type of anticoag to prevent clots in the future. Yep. Problems of risk must be managed to achieve these outcomes. Remember, aspiration risk is gonna be a big one. Maybe get speech therapy involved with that. Changes in motor function, so speech therapy, physical therapy to maintain that baseline of ADLs, OT as well. Might have to do ventilator support. Might have to get fluids on board, vaso support as well.
Home care.
Home care, make sure what kind of equipment that he might need at some point. What about emotional support?
Of course.
Always providing emotional support to our patients. Don't call me for that, because I'm not great at it at all. What about DVTs? So Josh kind of brought up that question, anticoags at some point, we'll consider those as well. My emotional support is always humor, and that's not what they want to hear, so. Okay. What interventions will the nurse implement to provide care for this patient?
A swallow test,
Swallow tests, okay, good.
maybe the STDs, the.
SCDs, yep.
OT,
OTPT, we already said that, that's good too. The number one thing, remember, is your changes in LOC, your NIH stroke scale, your neuro assessment. Monitor the vital signs frequently. Administer that thrombolytic therapy if it's an ischemic side. Hemorrhagic, we're not going to. Eventually do that swallow study. Early mobilization, good, we're kind of hitting all these over and over. We've kind of gone over this already as well. Let's do the case study too. Okay. All right, Mr. Daniel Cruz, 47-year-old male, brought into the ED following a motor vehicle collision. He was the unrestrained driver in a head-on crash upon arrival. He's got a history of hemorrhagic stroke 2 years ago. Epilepsy, well controlled with your Keppra and hypertension medications, Keppra, lisinopril. He doesn't have any anticoags at the moment. His initial assessment, GCS of 10, he opens his eyes to pain, he got incomprehensible sounds, and he withdraws from pain. Pupils are 3 millimeters, equal and reactive. BP is 178/92, heart rate 54, respiratory rate 12, but it is irregular. SpO2 91 on 2 liters, edge Kenya. What test am I gonna order?
SCT.
I'm not gonna order, where's my physician gonna order? CT, right? Potentially a chest x-ray. Okay. So the head CT revealed a large left-sided cerebral hematoma with a midline shift. The neurosurgeon placed an ICP monitor, sent him to the ICU. Okay. Over the first 12 hours, his ICP values fluctuate between 15 and 25. At 0200, the RN notices his ICP spikes to 32, with changes in his neuro exam, sluggish pupils, posturing, and worsening GCS.
Call the doctor.
Call the physician, I like it, okay. Let's look at question 1 here. Which nursing intervention is a priority when Mr. Cruz's ICP suddenly rises to 32?
C.
C, elevate ahead of bed at 30 degrees. Anybody else disagree? Everybody like C? Okay. Reposition the patient flat in bed.
No.
That's gonna increase my ICP, right? Structure the airway aggressively for 30 seconds. That's gonna make them cough and gag, really increase that ICP. Remember, less than 10 seconds on that. And then administer large fluid bolus to increase cerebral perfusion. Yes, it's gonna increase my cerebral perfusion, but that's also gonna have a large amount of volume within my intracranial space. So that's actually gonna increase my ICP even more. I'm trying to decrease my ICP overall. Good. Question 2. Which nursing intervention helps prevent further ICP elevation?
B.
Administer stool softeners as prescribed, I like it. C, maintain normothermia and treat fever, good.
D.
D, limit suctioning for less than 10 seconds,
And that's it.
and then that's it. Okay? Remember, clustering care is good for most of your patients to complete all your tasks at once. But I gotta go in there and do those frequent neuro checks, frequent assessments. If I cluster that care and then I wait 12 hours to go back in the room, he's gonna have some kind of big neuro event in those 12 hours. So don't be that nurse, right? And then encourage the family to stimulate and talk loudly to the patient. That's just gonna get him anxious, excited. All that stimulation, awakeness is gonna increase that ICP as well. Given Mr. Cruz's history of epilepsy and current head injury, which seizure precautions are appropriate?
A. B.
A, okay, good. Her B, good.
E.
Everything except for D.
Do I need continuous EEG monitoring?
Not really, no.
Not really, okay.
So A, B, and E.
A, B, and E, good. Oral airway inserted, your keyword here, all times. I don't need one at all times unless he just needs it. Unless you're an ICU nurse, then you want an oral airway. But other than that, I don't really need an oral airway. So A, B, and E. Good. Question 4. Despite interventions, Mr. Cruz's ICP remains elevated and his neuro exam worsens. His family asked, what happened if the pressure can't be controlled? What is the best nurse's response?
A.
Here, A. Anybody else got anything? Anybody like A? Okay. He may need a decompressive craniectomy to relieve pressure. Alright. Increase fluids to keep his brain well perfused. Yes, in theory, but that's increasing my ICP as well. It's too early to know. We'll just keep watching. That's really not having a comforting approach to that as well, and it really doesn't answer their question. I like that answer though, it's funny. Once ICP rises, there is no treatment available. Well, that's not true, there's plenty of options out there, okay? Usually when I answer these questions, I say what I would not say. That's usually the answer I do, okay? This is something I would say right here, and then I wouldn't even pick that answer, okay? I'm bad about this. I struggle with these types of questions in nursing school, so. You're admitting a 24-year-old client with a history of epilepsy who reported having missed their last 2 doses of Keppra. They state, I feel a little off sometimes. I know a seizure is coming. Vital signs, heart rate 88, BP 132 over 78, respiratory rate 16, SpO2 97 on room air. Anything out there jump out to you?
They missed
No.
their medicine.
Missed their medicine, the last 2 doses. I feel a little off, sometimes I know a seizure's coming. Right? What about vitals? Anything stand out?
Your blood pressure's a little high, but it's okay.
It's not bad. Which intervention should the nurse implement immediately?
A,
B.
B, C,
And E.
E.
A, B, C, and E. What about D? It's lonely.
What I need that for?
What do you need that for? Probably don't need it. Place the bed in the lowest position. That just makes sense overall for any patient we have, regardless if it's a seizure or not.
Y'all know I'm gonna make y'all laugh, so.
TikTok thing. Insert IV. Pad the side rails of the bed. Ensure suction options are available. All those safety interventions for seizures.
Do they make padded dumplings?
They make like blocks.
Like they do make buy blocks, so I guess they do. I have made a padded tumbler before.
Where you put gauze and just tape it.
Gauze and tape it around the, like a tummy pressure, so they don't bite their tongue out. Not during a seizure for other issues. While in the unit, the client suddenly develops a tonic-clonic seizure lasting 90 seconds. The client is cyanotic and drooling. What should the nurse do during the seizure? So this is prioritization wise, we'll rank the following in order.
Number 1 is number 1.
So one, so, well, I'll say 2. No? I don't know.
I say 3
I mean, 'cause
and
if they got restrictive clothing around their neck and they're seizing, you finna choke them.
I think you're gonna turn them on their side first because they can aspirate. 1,
One,
2,
3 and 4.
3 and 4.
I'm just saying 4 for real.
Yeah, because
Well,
actually just not
Yeah,
the
1, 2,
3 yet.
3, 4 for real.
Does not.
Uh,
So 3, 1, 2, 4. 3, 1, 2, 4.
You gotta move the stuff out of the way.
Move the stuff out of the way. Alright, they're actively seizing. Move everything out of the way. This is all gonna be in very quick succession. In real life, you're gonna do all these things at one time, basically. Okay. For testing purposes, 3, 1, 2, 4, okay?
I don't like this question.
I don't like this question either, but,
So please don't put the write this on the test.
I hit it for you.
Make sure you move
I
that
tried,
bedside
y'all,
table
I tried.
I can breathe it.
I tried to help us
So
out.
3, 1, 2, 4, move that equipment out of the way from your bedside for safety, maintain his safety. He doesn't hit his head and cause a traumatic brain injury or something from occurring from that. Turn the client on the side to hopefully prevent aspiration. 2, loosen restricted clothing around the neck. That's really not that important. It is important, but not as important as some of these others. Administering O2, I can do that at the end if needed.
I mean, who's wearing a turtleneck in the hospital?
Maybe he was looking stylish, I don't know. He had a scarf on. or
Still wasn't
something.
looking very stylish with his turtleneck on.
He's seasoned with a scarf.
See, the little scarf on.
I should see flying furniture.
Seizure ends. Client is now drowsy, disoriented, and has urinary incontinence. We didn't put the airway on appropriately, apparently, because it's O2 is 88 on room air.
Maybe he's still got a turtleneck.
Which interventions are appropriate in the postictal period?
E, C, E.
I hear B, D, and E.
Oh,
Apply oxygen via nasal cannula. Immediate ambulate client to the bathroom. They're in a postictal state. So that's basically dragging your patient to the bathroom. That's not gonna be appropriate. Reorient the client when awake. That's probably a good one. He wants to kind of know what's going on, get him reoriented to the situation. Document seizure duration and characteristics. Documentation is important. Keep client sidelined. Anybody say that one?
I would do that.
I would do that too, right? Remember, they can have nausea, vomiting after that postictal state, after that seizure, to maintain their airway, prevent aspiration risk, keep them on the side. Okay.
If they're having a seizure and they have another cannula, do we just leave it on or is that a safety risk?
Shouldn't be a safety risk unless it like starts to go down like that scarf. And
Did anybody see my patient at Piedmont in the hallway after her seizure?
No.
This last rotation. Oh, God.
All right, big one here. 2 hours later, the client has another seizure lasting 6 minutes. IV lorazepam was given, but the seizure continues. Provider diagnosis status epilepticus. All right, so pick 2 of these actions. So prepare for IV administration, phosphatinone, I don't know why I have an extra bullet point there. Insert a nasogastric tube, anticipate possible need for endotracheal intubation, or apply lateral wrist restraints. So what 2 actions?
A.
So prepare for IV administration and phosphatinone. Everybody agree with that?
Uh-huh.
Okay, what else?
Intuition.
Intubation? Good, okay. Am I worried about NG tube right now?
No.
Nope, is that gonna help my patient live? It's not. Alright, bilateral wrist restraints.
That sounds terrible.
I like bilateral restraints, but not for a seizure patient, okay? Remember, we're not constricting their movements, alright? Outcomes. Let's select 2 on that side. Maintain airway and oxygen.
And prevent.
Prevent reoccurrent seizures. I have a lot of extra bullet points. Yes, so remember, my actions, I'm giving Dilantin to hopefully prevent reoccurrent seizures from happening, all right? I am possibly getting an endotracheal tube to help maintain airway and oxygenation. The client recovers and is preparing for discharge. Which discharge teaching points should the nurse include?
A. B.
A, B,
C,
C.
C,
E.
E.
Oh, it is safe. No, no,
D is not appropriate because remember keyword alone, as long as you feel well, okay? If he has a seizure in the pool, he's gonna drown, alright? So take antileptic medications at the same time daily, yes. Avoid alcohol and sleep deprivation, remember that could be a trigger for a seizure potentially. Certain states do require you to, have a seizure-free state for at least 6 months or be controlled on some type of medication for a while before they're allowed to drive, so there's definitely some restrictions involved with it if you're diagnosed with status epilepticus or some type of seizure disorder. And then identify and avoid seizure triggers if possible, so that's good. Okay. Right. Last one. Questions with the neuro case studies? Nope. Okay. Somebody asked me what type of questions am I gonna see on professionalism, leadership, and management? How am I gonna get tested on that? So this is gonna be kind of a review of how I'm gonna get tested on that type of stuff. So remember, professionalism is about how you interact with your patients, how you interact with your staff, your coworkers, your peers, how you conduct yourself in a job interview, what type of questions you're gonna ask during a job interview, what kind of stuff I can wear to a job interview, what's my resume look like. That's your professionalism side of things. Your leadership and management side of things is gonna be your prioritization, your delegation, what things can I do or give to my, say my LPN or my UAP or my multi-care technician, that kind of stuff. And what immediate nursing action or intervention do I take care of first? What patient do I see first? That kind of stuff, okay? Which patient should be seen first due to the highest immediate risk? So chest pain with diaphoresis and shortness of breath, postoperative patient with incisional pain, fever of 38 degrees Celsius with mild cough, or a patient requesting analgesics for knee pain.
A.
Everybody got A. Anybody disagree? Nope. So when it comes down to it, is my patient gonna die with a fever and a mild cough?
No.
Nope. Postoperative pain with incisional pain of 2 out of 10, that's expected, right? 2 out of 10 is really not that bad. All right, I can delay care a little bit. Probably don't need to delay it all day, but you know. Knee pain, 3 out of 10. He's just requesting some pain meds. Does anybody ever die from pain? Not necessarily, okay. Chest pain with diaphoresis and shortness of breath. Possible MI here. Immediate emergent situation, probably need to do something about that, okay? Correct answer, A, good. Chest pain with diaphoresis and shortness of breath. During shift handoff, which factor has the greatest impact on prioritizing tasks?
A.
Okay. Anything else?
D.
Well, is this a select all that apply?
It's not.
Oh.
So patient safety is good. So that kind of goes back to that question one. What's my highest level of priority? Remember on our leadership and management slide where it had the pyramid and it had the ranking system of my prioritization. So remember, acute, immediate things are going to be first. So something like an MI or an obstructive airway. And then you're going to have things that could potentially turn bad. So something like pain, something along those lines. And then your lowest level of priority is going to be teaching, discharge, education, that kind of stuff. Remember, falling is going to be at the top of the list because that could be the potential for patient harm. Okay. During code blue, what is the first action the nurse should take?
C.
Anybody else? Anybody like C?
What?
Now.
Wrong answer on that one. Check for pulse. Yeah, probably check for pulse. Yeah. Depending on what rhythm it's in, but yeah, check for pulses first. Sorry, guys.
Assess.
Now, you
Should assess your
change that because you had me thinking I was wrong.
You might have been wrong, man. I like to keep you on your toes, so,
Well, thank you.
there you go. Which task is commonly appropriate to delegate to an LPN?
B.
Okay, administer oral medications. Everybody like that?
Yes.
Okay, good. Remember, develop patient plan, care plan. That's initiating or developing. That's more of a registered nurse task. Complete the initial admission assessment and then interpret. All right, a little bit higher level than LPNs traditionally are going to go for, so they can administer oral medications. All right, what about a UAP?
D.
B.
Assist with activities of daily living, good. They can't perform a sterile dressing change, they can't initiate lab testing, or they definitely can't give any type of medication. Should have changed up these answer choices too, that's okay. Don't know for next time. Which statement reflects effective leadership during delegation? Probably the one with the most words, right? Okay. So identify priorities, communicate them clearly, and supervise outcomes. All right, if you're not doing any type of delegation, if you do it yourself, delay task until later, that's really not appropriate. And avoid documenting care, we definitely can't do that. Which task would you address first when prioritizing care for multiple patients with competing needs? So what is the first priority that I'm gonna see here? Give PRN analgesic to a patient with 3 out of 10 pain, move a patient with new onset chest pain to a continuous EKG monitor,
That
administer daily vitamins, or administer antibiotic order.
one. B.
So B, that's my highest level priority. So you kind of have competing concerns as far as administering daily vitamins, antibiotic orders, and giving a PRN analgesic. Once I take care of B right here, I can kind of work through these however I see fit or appropriate. But my number one priority is gonna be B there. Safe delegation to a UAP.
A.
A? Okay. Can they administer anything? Nope. They can't interpret anything, can they? And they can't develop a plan of care. Alright? What if it said, patient with difficulty swallowing? Can they help feed and assist with that?
No.
No.
Yes.
Right? Because they can't interpret or assess if they need a higher level of care, if they're adequately swallowing appropriately. Alright, that's gonna be more of a complex care system, so they really need a higher level than just a UAP. Which prereq supports effective delegation and patient safety? How can I delegate appropriately? A, good. Clear and updated care plan. Remember, I gotta know what's happening to my patients before I can delegate. Alright? If I don't know anything about my patients, if I give an LPN an insulin drip, is that gonna really make sense? Or initiating a normothermia protocol, can the LPN initiate? No, they have to maintain or monitor, right? So I gotta know what type of care plan, what type of updates, kind of get an overall idea of my patient load, my resources, before I can go out and delegate. Best approach to discharge teaching to ensure understanding. Probably A again, because a lot of the answer choices are A, so. Provide, teach back, and confirm understanding. That closed loop communication, remember? Good. Nurse is caring for 4 clients. Which client should the nurse assess first? Client with COPD exacerbation, who has been on oxygen sat of 91 on room air. Client 1 day post-op who reports pain rated 7 out of 10. Client with heart failure who has gained 2 pounds overnight. Or client with diabetes who reports new onset confusion.
D.
D? Everybody agree with D? Okay, good. Let's talk about these, and this is kind of how we're gonna break down these questions when you see it on the exam.
Wait a
Uh-oh.
minute.
Yeah, that one wrong too. Yep, client with diabetes who's reporting new onset confusion. COPD, O2 sat 91% on room air.
Expected.
That's expected, right?
Yes.
Okay, good. Client one day post-ops reports of pain rated 7 out of 10. Is that expected?
Yes.
Yep, that's pretty normal. Heart failure, gaining 2 pounds.
Yes.
That's probably pretty expected. It's a little concerning, but it's expected, right? Yeah. Diabetes, confusion, that's not something expected. So. Task, again, so reinforce bathing and basic hygiene, assist with ambulating and transferring, documenting intake and output. Remember, the UAP can do that, but they can't administer any type of medication. RN oversight, it cannot be delegated to the LPN or UAP. A, interpreting, okay. B, developing the care plan.
A and B.
Yeah, just A and B.
Okay. Good. LPNs can do routine dressing changes, administer oral medications. UAP could probably assist with routine dressing changes. Nurse receives a report on 4 clients. Which client should the nurse see first? Client with pneumonia requesting pain medication. Client with AFib. Client with chest pain, UST elevation. I like that. Good. All the rest of them gonna be kind of expected, right? Nurse is caring for client with increased ICP. Which intervention is the priority?
B.
B. Good. Awesome. Good job, guys. Okay. Questions about anything? Like I said, remember, look over your neuro study guide. There's a neuro review visual out here that looks pretty good as well. Signs and symptoms of shock. Really good PDF to put out there. Got the podcast. I will put out the perfusion slides so you can review your EKG strips. I'll also put out some notes for your neuro review. The case studies will come out eventually too. Please sign the roll if you haven't done that already. Remember, constant communication with your preceptorship stuff. All right, I know a lot of y'all are starting to meet with your preceptors, starting to get your contracts signed. Remember, the contract is front and back, so make sure you fill both sides out. Get that signed, return it back to me. You can't start your preceptorship until everything is signed and turned into me. Remember, initially, you can send me an email of your scan of your student preceptor contract, showing me that you have everything signed. I will give you initial approval until you bring it to me, and then I'll give you finalized approval from there, okay? So if you have any questions, concerns about anything, please let me know. Constant communication. Okay? Questions about anything?